I hope you were able to join the early part of the beginning of the conference to hear some really interesting words of inspiration, but also the work that Amber Simpson was doing. And there's also a keynote speaker after our session as well. Please stay tuned for that. So first of all, I want to welcome all of you to our panel, but also welcome our panelists and thank you very much for being with us and sharing your time to talk about the work that you do. And our health panel is really more broadly around addressing health disparities and access to healthcare, sort of a broader theme, and really in the theme of this conference in terms of dealing with issues of inequity, social justice, and what can we do about it. So I'm going to just begin today and have asked ahead of time each of our panelists to sort of give a little introduction around the work that they do and their organization, or perhaps the research they're involved with in academic context as well, and talk a little bit about sort of what's the challenge of that work you've been doing, kind of the outcomes of that, and sort of obviously the success. And I think coordinate and have each of our panels sort of end with kind of what can we do, that is us collectively, not only as the group that's here, but those that you join us as well, those at the conference and too. So anyway, my name is Barry Brinton. I'm the Faculty Engagement Associate in the Center for Civic Engagement here at Binghamton University. I'm also a practicing applied medical anthropologist as well. So this is a great interest of my own work in terms of issues of equity and health. And I want to make a clear point. I think we all realize still in the middle of COVID now, and all of you will probably touch upon that challenge to all the work that you've been doing. But just to realize that for those of us who work in the world of health, generally speaking, or social justice, we know that the gaps that we saw in COVID-19 were gaps that we already knew about. It was nothing new. We just saw the gaps get wider, open and shut and get wider again. And of course, those most vulnerable or underserved communities have had the biggest impact in terms of COVID overall. So I always say, we're moving forward. People want to get back to business as usual. My primary comment is no, it should not be business as usual. You need to really recognize here's the time, here's the point of action where we can move forward with that. All right, so I'm going to just introduce each panelist as they then will give their presentation. So I'll just not introduce you all at once, but sort of as we go through the course here. All right, so we'll start out with Judy Correnta. She's an associate professor in the Decker School of Nursing. So Judy, I'm going to turn it over to you to share the work you've been doing.
Well, hi, everybody. Welcome to the panel. Thanks for coming. I address access and health equity and disparities through, I think, kind of a unique lens. And I address it through multiple prongs. First, we have to identify where the health issues are, where the disparities are. And then as a nurse, how do we go about addressing that? So one thing that I believe is really important is whatever interventions we do, that they're evidence-based. And how do we get evidence-based interventions? But we need practitioners who can go out, gather the data, know how to interpret it, and know how to actually implement it so that we can make changes that we know are really effective. So to that end, I developed a course in conjunction with the Center for Civic Engagement. It's a community engaged learning course. And I have undergraduate and some graduate students now working with me to address specifically needs of asthma in the community, which is the #1 chronic illness in the community and actually globally. It's a huge issue. And what I do is I train these undergraduate students, and they're nursing students, and they're students from all disciplines. They just don't have to be nursing students. And I train them how to do research, how to implement research, how to make sure that we're doing the best practice, and get them to have a love of research so that then they can go out and be able to affect change in the future once they're professionals. So one of the interventions that we do is to address the issue of asthma. Asthma is the #1 cause of absenteeism in schools. It's like the 3rd leading cause of illness, chronic illness in the pediatric population. It impacts quality of life. It impacts their ability to learn. So what we have done through our course is all our students are trained as open airways facilitators. So we partner with the American Lung Association. And in the past, I used to do the training. I was a train the trainer. And now American Lung has become a lot more involved, which I love. And they actually do the certification for our students. And our students become a facilitator for this open airways program, where once they're trained, it's a national certification. They can now go anywhere in the country and teach this program to kids. And the program is to teach children ages 8 to 11 or around grades 3 to 5. And we do some leeway with that. And we teach them how to manage their asthma. You know, we don't really know how to prevent asthma. They're starting to do a lot more, you know, bench research on asthma so that they understand a little bit more about how it's occurring. But once you have asthma, at this point in time, you're always going to have asthma, even if it's under control. So we teach these children how to manage it, how to address when they're having symptoms so that we can keep them out of the hospital. So even though we can't prevent somebody from having asthma, we can prevent somebody from having an asthma attack, from having asthma symptoms, from missing school, from ending up in the emergency room, and then subsequently ending up being hospitalized and sometimes in ICU being intubated. Asthma costs to society are astronomical. They're in the billions right now. They're not in the trillions, but the way our country's going, I'm sure with healthcare costs, it won't be long. But all of this is unavoidable. So my students are trained to go, and we go into the schools, and we do it over 5 sessions, and we teach the kids what is asthma. How do you know what your early symptoms are so that you can intervene right away? What are your triggers? What are your medications? And then how do you know if you're healthy enough to go to school? Because we have these little guys who, if we can't keep them in school, if we can't keep them engaged, if we can't keep them becoming very functional in society, then we're not going to have adults who can really give back to society and then be there for us, especially me, because I'm going to need their help pretty soon, so that they're there for us. So my students teach it over 5 sessions, and we do pre and post tests to see, do we make a difference in outcomes? And what we found is that by teaching open airways, we truly do indeed increase the kids' self-efficacy, and we increase their knowledge. We haven't done longitudinal studies yet to see, does it really make a difference? But other research on open airways, because this program's been around since the 70s, it keeps kids out of the hospital, and it keeps the parents engaged. What we found through research, and those of you that work with families and work with children, sometimes it's really hard to get the parents engaged. So through open airways, we not only teach the kids, but then we send information home to the parents so that they also have the information. And we really find that when the kids are teaching the parents what they learned in open airways, it makes a huge difference with that. And in the past, we've partnered with the health department so that when we're teaching the kids open airways, we're also going into the homes and we're doing home assessments, and we can actually help parents understand what is it that's triggering their child's asthma so that we can actually make a difference in mitigation of those. We were very challenged when COVID came because we were physically going into the schools to teach the kids. And once COVID came, obviously we couldn't do that. And we were in the middle of teaching open airways in one school at that point, so we had to just stop. But with another school, we hadn't started yet. So we actually did it by Zoom. And because it was so confusing, I actually did it myself. I didn't make my students do it that semester. But I realized, like, using Zoom, it was a very effective way to approach the kids. So the next semester, when we all came back, but the kids were still remote, we still did open airways, but we did it with my students through Zoom, and we got really, really good results showing that we can still be virtual and we can still have the great outcomes. What we're going to do in this coming semester, now that the kids are back in school, because it is hard to keep the kids' attention when they're in their living room, they've been in school all day, because we did it in the evening because the kids had to be programmed during the day. We're now going to do it virtually, where my students are virtual, the facilitators are virtual, but the kids are in school. So the kids might be gathered in the nurse's office, and then we're going to teach a group of kids and to see how, if we can be very effective with that. This will be the first time we're doing that in the spring semester. So it's kind of exciting to see if we can affect change with that. And then one other project that we're doing that I'm really excited about, and again, the Center for Civic Engagement has been very supportive, is we've developed a pediatric well-being picture scale where we can screen for kids' well-being. It's not a diagnostic tool. We can't diagnose depression or anything like that, But we did a search of the literature, and there are no tools for kids that are just pictures. And as we know, our literacy levels are not very high, and every child and every adult reads at a different level. So to give somebody an assessment tool where they have to read the words, and then it's usually a Likert scale where they have to pick the correct one that fits them today, that's really high level thought. That's really at the highest level of cognitive ability that we have, and most adults really never even get to that. So we developed a tool. It was based on an adult tool where it's 3 pictures, and the child will pick the picture that best depicts how they feel that day. So like I said, we modified it from an older adult tool. We did focus groups last year. We got their feedback on the pictures. We revised it. We brought it back to them. So we did our face validity. We did our content validity. And now we're in the process of doing our test retest reliability to make sure that our questions are consistent. And we were funded for that. And we actually made it a mobile application so that we can bring kids a tablet, and then they can just do touch screen. It will talk to them, so they don't have to be able to read anything, and they can just pick the pictures. Unfortunately, I mean, we got money for that, and we're really excited about that, but because of the supply chain issues, we can't get the tablets. So we've been waiting now, I'm going to say more than 2 months for tablets, because right now we have to go through Binghamton University. So next semester now we're going to do the test retest reliability. And then we're also going to give our tool alongside a validated tool so that we know what our cutoffs are. Because right now our tool goes from 0 to 20, but we don't know if somebody gets a 15, does that mean that they should have an intervention, or does that mean they're fine and good to go? So that will be our next test for our reliability, but we are really excited about that. And my students, we were approached by Sage Research Methods. Sage is a publishing company, and they asked us to write about challenges doing research during a pandemic, which was extremely challenging because we ended up having to do our focus groups by Zoom and doing all our analysis by Zoom. And my students, I have 13 undergraduate students now that are published. So Sage accepted our chapter. We just have to do minor revisions, but it's been accepted. And we now have 13 undergraduate students that have been published, which hopefully will be an impetus for them to continue on with their research. Because I'm sure, as with any discipline, nurses are aging out. Nurses with PhDs are still less than 1% of the population. If we think about the nursing shortage before COVID and the nursing shortage after COVID, it's astronomical. So if we don't have people going into the profession and achieving their PhD or DNP now to be able to teach, we're not going to be able to produce more nurses. And that's one of the major drawbacks or hindrances to be able to repopulate our nursing field, is that we don't have enough people to teach them. So hopefully through their participation in my course, and we have other courses as well, is that they're going to be able to utilize research, they're going to be able to implement the best practice, and they're going to be able to increase our knowledge of how to do the best practice, and they're going to go on and be able to educate new nurses so that we can address the nursing shortage. I was going to set my timer, Barry, and I didn't. I don't know how much more time I have, or am I out?
You're right on time. You wrapped it up really nicely.
Oh, okay.
Thank you, Judy.
Thank you.
I just want to say to those who have joined us just quickly, I mean, after we hear from all of our panelists, we'll definitely have enough time at the end for your questions as well. So we'll save those until we've gone through the panelists. All right. Thank you again, Judy. It's always great to hear what's going on in the updates. All right. Next, I'm going to turn to actually Mary Maruskak, who's from the Rural Health Network here in the Southern Tier region, and she's a director of actually community health education. So Mary, I turn it over to you.
Yeah, thanks, Barry, and good morning, everyone. So just a little bit about the Rural Health Network of South Central New York. Our mission is really centered around health equity for rural people and communities. So pretty much everything that we do here across our programs, whether it's health education, health services, which is more like resource referral, case management, our transportation and mobility travel training program, our food and health network, healthy food access program, our technical assistance that we're able to offer. It's really focused on recognizing health inequities for rural people and rural communities, and then working to address those. And I think getting to what you asked about challenges, Barry, I think it's really, what we have come to recognize is that so many challenges to addressing inequities come from the fact that inequities are systemic. And so we could create all the programs in the world, but if we're not addressing root causes that are coming from those sort of systemic concerns, then we're really just sort of putting a Band-Aid on an issue. So an example of that is we have, as I mentioned, we have a transportation and travel training program that provides sort of first and foremost non-emergency medical transportation for people who need it to get to appointments and health services and things like that. And it also does travel training. It helps with it helps people with finding resources that are in their community to get them where they need to go and all of those kinds of things. But it's not really enough for us to hear someone say, well, I don't have transportation, and then we just find them a ride. Because there are probably a lot of factors and a lot of reasons that that person or that family doesn't have transportation. And what are the root causes and what led them to calling us, as opposed to being able to sort of figure out what resources were available to them on their own. And so that's the real challenge to this work, because like I said, we could get all the funding in the world. We could come up with all the great ideas for programs in the world. But if we're not looking at those root causes and figuring out ways to address them, we're really not solving the problem. And I think the other thing that I would mention, and this sort of is part of what my program does at Rural Health Network, in addition to overseeing evidence-based health education programming for people with chronic health conditions, I also develop workforce development and training curriculum. And so the one that's burgeoning, that we're working on right now, that has been a real, it's been a big project throughout the pandemic, because I haven't been able to do group health education because, we can't responsibly have people with chronic health conditions all gathered in a room together doing group health ed. So we've really turned our focus to really sharpening up what we have available for workforce development. And so we have trainings focused on the social determinants of health, cultural competence, health literacy, and health equity. And the sort of catalyst for that is the recognition that our colleagues and our networks in the health and human services fields are not getting comprehensive education on those topics as they're moving toward their licensure and their degrees. And that's, we speak from our own experience. I have, an associate's degree, a bachelor's degree, a master's degree, and a certificate program from SUNY Albany. And it wasn't until the certificate program that I was even educated on what the social determinants of health were. Conceptually, I knew, but I didn't know there was a name for it, and so we're finding just as, across the groups that we're in, and when we hear people say, well, my patients they're just not showing up because they don't care, or they just don't care enough to get their kids to their preventive care appointments, or they just, it's probably not that they don't care. It's probably that they're waking up in the morning and they've got all of these health disparities that are stacking on top of each other. And then by the time that healthcare appointment rolls around, it has really sort of sunk to lower on the priority list because there are so many other emergent needs that people are dealing with. And as I said, we're finding that is not necessarily comprehensive education that we are getting as we're moving toward our sort of our career goals. And so we have developed some trainings, and we're sort of piloting some things now, and we'll start marketing more to get them out into the community, and looking at partnerships with our educational institutions to really start giving giving people that sort of base knowledge on what our patients and what our clients are kind of dealing with in their own home lives, in their own circumstances, and how those might be influencing their knowledge, their skills, their health behaviors, and the decisions they're making for their families' health that potentially could be leading to more negative health outcomes. And so those are really things that we are, I mean, that's sort of a description of what I'm working on, but those are really all things that we are continuing to think about across all of our programs, just in terms of, you know, being able to look at those root causes, what's causing health inequities, and being able to address them as well as we can from the community level, knowing that these are much bigger systemic things that certainly didn't happen overnight, and they're not going to be fixed overnight.
Thanks so much, Mary. In fact, I just met with a group of surgeons that were at the Creighton Medical School. They're actually doing their residency. So they're well into their careers as doctors, as surgeons. But when I spoke to them about this exact topic, social determinants of health, yes, they understood it sort of conceptually, but the bigger picture, they had never had any conversations around this. And again, these are, again, medical professionals being trained. So I agree, this is a big topic and a big issue to address. I just had one quick question though, Mary, if you could, in terms of those that are listening and to our panel here, either in or not in the health area, what kind of suggestions might you have to sort of better educate our general public around these issues that we could sort of take away?
So yep, we do the best we can. We are, well, I guess I will use COVID as an example. So we have a project that we have going right now is that one of the things that our organization does is we're a regional hub for AmeriCorps National Service Program. So we have on any given year about 25 AmeriCorps and Vista members that we work with community partners across the 10-county region and who serve as host sites for those AmeriCorps members. And so one of the sort of initiatives within that right now was one that was created by New York State in response to vaccine hesitancy or vaccine opposition. And so we have Public Health Service Corps members located here at Rural Health Network whose whole job is to keep an eye on those sort of burgeoning and consistent concerns that people have about COVID. And then as the Delta variant became something that was really impactful, and now vaccines, you know, what are the concerns that people have? And so we pay really close attention to literally like social media comments every time there's a post on a county public health Facebook page or whatever. We have Public Health Service Corps members that are really looking at that, and then they are developing educational materials for a lot of different modalities. So we're doing you know, social media posts, we're sending things out through our monthly newsletter, we're creating products that we can share with our community partners that are just filled with like clickable links and things like that. So, you know, as everybody knows, this information is kind of just constantly changing, which is one of the reasons that people are so resistant. But to be able to create sort of a clearinghouse for people to be able to know where to go to find that consistently changing information. We have also set up what we're calling a warm line. So we have a Public Health Service Corps member who has been doing a really great job keeping herself educated on all of these changes. And so for 2 days a week for about 4 hours, she is available at a phone where literally anybody can call in, and if they have any questions at all, she just sort of keeps the most updated information at her fingertips, and she's doing a really great job. Just, you know, it's a really informal, sort of non-judgmental, just open the discussion kind of approach. And I think she's doing a really nice job with dispelling some myths. And it's it's working well, I think, because it's very low pressure. It's not a person needing to have a conversation face to face with their healthcare provider. It's, you know, nobody feels like they need to call the state of New York, or no, you know, people are literally able to just call up and say, yeah, I've heard 3 different things about this J&J vaccine. Can you help me figure this out, or can you clarify this, or why is all this information different, or whatever. And she's able to just, you know, sort of gently talk them through. And so we are just always looking for opportunities to do maybe what's a little bit unconventional, but what are people in the community saying, and what's the best way to respond to them in a trusting way, I think is really important.
That's great, Mary. Thanks so much for that. Sort of really having an organization that's keeping the pulse of the community around health education. I think that's so important. All right, I'm going to turn over to our next, I guess, team that's going to be going next. Jesse Natishak, who is a licensed master social worker and the Lord's Youth Health Service, the Lord's Ascension Health System here in the region, and also Lindsay Grinberg, who's a health coach also with the Lord's Health System as well. So I'll turn it over to the both of you.
Okay, so I can go first. So thank you so much for giving us the opportunity to speak here today. So as was stated, I am a health coach with the Lord's Asus program. Asus stands for Adverse Childhood Experiences. And what we do is we try to take into account a person's past trauma history and to determine how that could potentially negatively impact health and wellness into adulthood. So we work with adults primarily, 18 and over. And what we know from the original CDC Kaiser Permanente study on ACEs is that they broke it down into 3 categories of abuse, neglect, and household dysfunction. From those 3 categories, an Asus survey was created, known as the Asus Survey. And basically, you just take the survey and you answer questions yes or no, questions 1 through 10. And at the end, you get a score of 0 to 10. The relevancy of the survey and knowing your score shows a direct correlation between an increase in ACEs as well as an increase in negative health outcomes later on in life, such things as like mental illness, substance use, chronic illnesses, including but definitely not limited to things like heart disease, stroke, cancer, COPD, diabetes, and even early death. So studies have proven that there is an epidemiological correlation between the higher ACEs scores and somebody suffering from the negative health and wellness outcomes as they age. Oops, sorry, that's my work phone. This is in part due to the psychological trauma that ACEs cause. Without having supportive people in their lives, without having access to supportive services, being able to develop healthy and coping skills, building resilience, managing stress. But it's also in part due to the toxic or chronic stress that somebody experiences that actually impacts brain development. So MRI studies have shown that the higher the ACE score, the less gray matter is actually in key areas of the brain. So for patients who have a higher ACEs score, the gray matter in the prefrontal cortex as well as the amygdala are actually less, and it actually shrinks the hippocampus. So knowing this, we can better understand how ACEs can impact brain development, which in turn impacts functioning such as decision-making, self-regulation, fear processing, memory, and then stress management. So one of the goals of our program is to provide trauma-informed care approaches in the hopes to not only build resilience in individuals, but promote supportive services that they can utilize when looking to improve their health and their wellness. One pathway that we do that with is working with residents in various Lord's clinics. So we talk with the residents during clinic hours, during their orientation, we present during didactics about our program, not only about how ACEs impacts health and wellness, but also about how incorporating a trauma-informed care practice with their patients can actually improve patient engagement as well as health outcomes. So a very simplified version of what trauma-informed care means is just treating somebody like they have past trauma, whether you know it or not. So examples for this for the residents might look like asking a patient for permission before touching them to take vitals, explaining why that touch is relevant or needed in that particular examination or in that particular visit. Understanding why somebody with a past trauma history might not want to undress during an examination, why they might skip visits because that's a requirement if that's not expressed or kind of talked about or discussed. Using terms and wording that's easy to understand and not intimidating. Simple things like this can help create trust and build rapport for our patients as well as providers. So another pathway as a health coach, I talk to people about what their goals are, what they're looking for with their health and their wellness, where they're at as far as a readiness for change, focusing on their values as if it's intrinsic, if it's extrinsic. A lot of common things that I hear or people talk about are things like weight loss, stress management, sleep habits, nutrition, exercise. So within the Lord's Aces program itself, we actually offer a lot of free services and free events and stuff. So we offer free yoga classes taught by a certified yoga instructor. We have free fitness classes taught by a certified instructor from Synergy. We have free wellness information and education sessions, social hours where people could just come and hang out and enjoy and do like an art project or something, as well as a women's support group. We also do a lot of pop-up giveaways to try to address some of the needs that we see within the community that we work with. So recently we just had a turkey dinner giveaway. We have laundry support giveaway programs where we give away like laundry detergent, baskets, dryers, sheets, stain sticks. We also recently did backpacks that were filled with child products, so like school supplies. And then we had an adult backpack filled with like personal hygiene or household items. So all of our events and our programming takes place at the NOMA Community Center. NOMA is north of Maine. So for those who don't know it, it's a great community center. We partner with them. They're fantastic. They're located at 85 Walnut Street in Binghamton. And they themselves also do a lot of free programming for the community. So more recently, they did stuff like, they had like live music during the summertime. They have free meals on Saturdays for people. They did a neighborhood cleanup. They had a series of workshops showcasing local entrepreneurs and a lot of free stuff that's happening on a consistent basis there. So I encourage anyone who's interested in learning more about ACEs or trauma-informed care or adverse childhood experiences, if ACEs are short for. If you're interested, Google it. If you're interested, research on it, look it up. There's a lot of great resources out there. My personal favorite is Dr. Nadine Burke-Harris. She did a TED Talk on it, which was phenomenal. I believe she's the current Surgeon General for California. There's all kinds of studies, there's all kinds of books, all kinds of stuff out there. My only caveat to if you guys do decide to do that is just know that some of the stuff on there can be triggering. So there is a warning with that. So if you're in a place where you feel like you can take that survey and you can get your score, I encourage you to do so. If you have supportive systems in place, if you're in a good space as it is, know that the number that you get, whether it's 0 to 10, it's just an assessment tool. It's not a guarantee that you're going to have negative health or wellness outcomes. It's not a guarantee that the early death or the diabetes or those kinds of things are going to happen. It's just an assessment tool. It's something to be mindful of, something that you could know for yourself, as well as if you're comfortable sharing that with a healthcare provider, so that way they have knowledge of it as well. So if you want further information about the Lord's Aces program, I can ask that my work contact information be shared with whoever might be requesting of it. And for those who want to volunteer or participate with the NOMA community events or the events that we have there at NOMA, their Facebook page is actually fantastic. So I suggest please check that out. It's the NOMA Facebook page. And their coordinator there, her name's Brandy Brown. She has a lot of volunteers already coming in from BU, a lot of students, and it's been fantastic. And I'm going to hand it off to Jessie if she wants to add anything further.
Thank you, Lindsay. Hi, everybody. Good morning. So my name is Jessie, and I'm the social worker for the ACEs program through Lords. And Lindsay covered a lot of, like why we do what we do and where we kind of started. And we're a grant that started through the 303 clinic at Lords. To work primarily with the residents, and what we've grown in our own kind of way of expanding it to the community because we're at the community center. So we've been able to, kind of expand it and open it up throughout the community as well. But really focusing on that lens of trauma-informed care. The goal, one of the goals, there's many, but one of them is to change the conversation. And not only does this apply to residents, but it applies to really any service provider and any human being, essentially, who we come in, like we are constantly in contact with other human beings. But it's changing that mental narrative from, that instinctive judgment and shame we feel from looking at someone's behaviors or what we consider as like not appropriate or not right. And instead of thinking, wow, like, what's wrong with you? Why would you do those things? It's really like, what happened to you? Like, why are you functioning that way? Like is the survival mode you've been in for so long, and how come, and so that's what trauma-informed care looks like in practice. Lindsay talked about, like asking permission for touching and explaining thoroughly, like, this is the process, this is what we're going to be doing today. If you have any questions, just opening that invitation for people to communicate and feel safe. But in practice, as professionals and as colleagues and as, service providers and helpers and delivery of care, a lot of it is on us to really reflect and look at ourselves and like, well, what our thoughts are and what our shadow selves look like and how we carry ourselves. And it starts with us. Because what we feel, it's eventually going to come out to the clients we're serving. Those things, they do come out eventually. And the other thing with that is, it's important to recognize like our nonverbal and our verbal communication. So a lot of times it's like not what we say, it's how we say it. And a lot of times it can even be in our body language, So trauma-informed care in practice is like very complex. And it takes a lot of deep interpersonal work on us to understand how it's happening to the clients in the community. And a lot of what Mary talked about is really what we see when we talk about our challenges. We see a lot of that, like we're working with folks who've experienced intense trauma, and we're also working with folks who have serious systemic limitations because they can't access certain resources. They go to the doctor and they're told, eat healthy, but okay, but I can't. I don't know what that means, and so that's where we try to come in to break it down and say, okay, so the doctor said eat healthy. What do you think healthy looks like? And that's more of Lindsay's forte, but that's kind of what we do, is to be that gap between like providers and client and patient, so we can, person, so we can just try to make it work, more appropriate for them. I think, to me, like one of the biggest antidotes to stigma is trauma-informed care. And so if trauma-informed care says we should adopt this universal assumption that everyone has experienced trauma, right? And it's not up to me or you to say what trauma looks like for someone else. So we can look at that questionnaire that Lindsay had mentioned earlier of all these events that happened before our 18th birthday, but trauma does not happen after 18, right? Although that's our focus, is to look at the ACEs. We also know someone who's 19, 20, 21, all ages, can experience trauma. And it's not my place to tell someone, oh, well, that's not on the questionnaire, so that must not be traumatic, So it's like adopting this ideal and this lens that everyone at some point has experienced trauma. And if I put on those glasses instead of the what's wrong with you glasses, my work's going to be a lot more effective. And thinking about trauma-informed care, so there's 5 principles, and this is really where my work gets a little bit thick. The 5 principles are safety, choice, collaboration, trustworthiness, and empowerment. And so those are not linear, right? So it's not like, okay, you come in and we build safety, and then we build choice, and then it's collaboration. Like, it's not this linear thing. It's really meeting someone where they're at and knowing, like, we do provide a service that's therapeutic for trauma-informed. It's a trauma-informed therapeutic service for people who've experienced trauma, but I have to make it very clear to people up front, like, you are not expected to come in and sit in a chair and tell me your deepest, darkest traumatic event, and like, we're going to unpack that the first day, even the second, third, fifth time, right? It may never come out, but if you're showing up and you're showing like a willingness to just want to be in this moment with someone in a therapeutic setting to learn how life has been impacted or just how things are going in your life today, right? We're there to have a conversation about whatever that looks like, because that's how we build that trust. That's how we build safety, right? It can take someone who's in survival mode with the hippocamp, like what Lindsay was talking about with brain, like, you know, all this stuff we have to take into consideration, because just because someone has experienced trauma doesn't mean they're ready to come in and say, yeah, I'm ready to change my life and figure everything out and go on with it. Because again, we're up against those barriers that Mary had been talking about. So it can take a long time for someone, but as long as they're walking through the door and showing up, that's the most beautiful thing they can do for themselves. And then it's up to me, you know, in my practice, I firmly believe it's up to me to make it clear to someone that they have choice. Like, you don't have to be here if you don't want. You can terminate this at any point. It's completely up to you. You have the power, right? Because trauma takes power away. Any traumatic event, we are left powerless. My goal is to say, you do have power. You have power right now as far as the work we're doing. You know, you're in the driver's seat. I'm just riding along with you and helping you as a co-pilot. That's it. And it's really up to you. And that's where we can then collaborate. And the end goal, the start and the end goal is that empowerment, you know? And that's why it's important to say, you know, you're not going to come in and have to tell me every deep, dark secret. You know, we'll get there when we get there, when you are ready. But let's build some trust. Let's find some safety that you maybe have never found in your whole life. You know, how are we going to do that? And I'm here to take as long as you need to do that. So that's kind of like the idea of what we do in practice. And some challenges we face are really a lot of what Mary talked about is if we have someone who's like basic needs aren't met and they have no idea how to get those basic needs met, but they also have an extensive trauma history, what comes first, right? Of course, basic needs are going to come first, because they can meet with me and we can sit, and I'm more than happy to do that if that's what they would like. But if they're hungry, if they are couched, like if their basic needs aren't met, the chances of them digging through that deep stuff, act like thoroughly and effectively are a lot lower. It doesn't mean it can't happen. It just means that it's a barrier that we face together, right? The patient and the client and I and our team, we face that together. And some of our successes, I think, are, you know, the people who do attend and the things that we're able to do. And I mean, we're a grant program funded through the hospital and funded through Mother Cabrini. And it's great because we, just like a grant, we get money and we're allowed to do things with it, right? And the things we do target those basic needs, make it so that people are starting to build that trust with us, so that people are starting to see, wow, that's a safe place. They do, you know, like it's a welcoming environment and there's no pressure there. They're not forcing me to do anything I don't want to do. There's no contingencies, you know, there's no fine print and strings attached, which is another huge thing in our community. So we have a lot of successes despite the challenges, because trauma can be a huge challenge for folks, but we're there to work with them for that. And then the last part of the request was, you know, how can people help, or how can you, you know, get involved? Lindsay talked about that. Like if you're interested in volunteering, you know, if you're interested in just chatting with us, I can't speak for anybody else. I'm open for communication, you know, email, phone call, whatever. But I think the best thing to do is what I talked about earlier, is like really looking at our shadow selves. And this is like my invitation to all of you, because we have stuff too, right? And I think that a lot of the folks in the community are very scarred from providers in the community, because there can be toxicity. There can be a lot of unprofessionalism because some folks are delivering a service that they're not fully equipped for, right? Especially when it comes to substance use and trauma and these heavy things. It can be easy to bleed on a client without even realizing it's happening. And I think it's up to us to be mindful of that. It's up to us to check our stuff and like really, really be honest with ourselves and, you know, take care of us so that we can take care of folks. Because if we're taking care of everybody else and burning out, because that's our identity, there's nothing left sooner or later, you know? So it's up to us to really put our mask on and figure out what it is we need, so that we can continue. And that's all I have. Thanks.
All right. Thank you, Jesse and Lindsay, for that insights, not only on the work that you do particularly around mental health, but also just in terms of that being linked to that community partner at NOMA in that specific case study, I think is wonderful. And clearly, as we talked about at the beginning of our conversation, that we all know that COVID-19 has again emphasized mental health as an issue. Let's just hope that it continues to be destigmatized at the same time. It's an important area. All right, so our last speaker on the panel is Liam Lane. Liam's a graduate student here at Binghamton University in the biomedical anthropology program. He's going to talk a little bit about his work he's been doing, particularly with the Broome County Health Department. It's been great to actually have Liam in my class on health disparities. And this is a project that he actually had begun before that in this program. So I look forward to hearing about this. So it's up to you, Liam, to take it over.
Yeah, thank you. Thank you first for having me too and giving us all this opportunity too. It's been great to listen to all the work that everyone else has been doing too. I've been writing down notes and it's been really inspirational too to also incorporate this stuff into my work too. So like Barry mentioned too, I am a current graduate student at Binghamton University, and I've been working for the past year and a half on a project with lead poisoning prevention in Broome County with the Broome County Health Department, but also with Dr. Deborah Schechter of the Anthropology Department at Binghamton University too. And what we're looking at with this project too is residential lead exposure in Broome County in particular. So a little bit of context behind lead poisoning and residential lead exposure more generally is in 1978, lead was banned from paint, and we see this a lot in older rental homes too here in New York, and it's a huge issue in just environmental toxins too, but also environmental exposures too and how that impacts health. So in New York State, about 75% of the homes were built before 1978, and a lot of them have this lead paint in their homes too. So what we look at, and the problem that we're really addressing is how does lead in these paints kind of become into dust, but also to how are they being exposed to the younger children too? Because lead does have a huge impact on childhood development, on brain development too, and other physiological programs too in the body. So the problem that we're really facing also is testing for this lead exposure. So there's no general signature for lead poisoning in the brain too, and a lot of different symptoms can manifest differently depending on not only the level of blood lead concentration in the body, but also just depending on age and other factors too. So what the problem in Broome County is that New York State requires children at ages 1 and 2 to be tested for lead poisoning. However, only 50% of children in the county are being tested currently. And more broadly in New York State also, from ages 6 months to 6 years, they should be going through a risk assessment for lead poisoning too. So our research, along with Deborah Schechter too, looks at addressing these issues, and we're currently working with providers, mainly pediatricians, but we're also looking to expand to OBGYNs too, to kind of get to these root causes of why providers aren't testing, if there's any barriers to testing, and then also using this information to then go back to the health department and work on educational materials and other outreach programs to get to these root causes of why people aren't being tested. Some of the things that we've looked at through literature reviews so far are if providers are recognizing lead poisoning as a problem, if they know what to do about it too, if they're looking at other factors. So kind of echoing some of the other sentiments that were said in this past panel too, like are providers thinking about these broader social determinants of health? If you are testing high for higher concentrations of blood lead levels, you need to go through other appointments too, other follow-up appointments, depending on those levels too. So do you have transport to these offices? Do you have transport to these follow-up appointments too? Do you have access to healthcare? Are you able to take off the time to work, or are you able to get childcare too to take care of other children? You have to bring someone else to an appointment. And looking at these other broader issues that surround healthcare and access to healthcare too. Another thing too that we've been looking at too through literature reviews, incorporating into our own work, is a stigma around lead poisoning too. So thinking about this is not a responsibility, it's not a fault on the individuals who either have these higher blood lead levels or do develop blood lead or lead poisoning, because it's an environmental exposure too. It's in their homes. It's a responsibility of the landlords, or if you're renting a place too, or if you have other spots that you're living in also. If your work is dealing with lead exposure too, and if you're coming home with that lead dust, on your body, if you're exposing your family, or if there's other environmental exposures too. What's the stigma around this too? Are people worried about addressing these issues? They're worried about asking questions about this stuff too, because there aren't a lot of different ways to solve lead poisoning too. So are people worried about how they might think or how they might be treated from providers? Another thing too, like I mentioned earlier, is practical and accessing these services. Another thing that we're also looking at too is healthcare provider attitudes also. So our providers recognizing this is the problem too, expanding this to a larger issue if people have access to these services and if they have also access to knowledge and the other resources available to them. One thing that we've been doing this past year, to echo what a lot of the people have been saying with COVID-19, it's been very difficult to do a community-based and then community-engaged research project. We've been having a couple focus groups the past year with some providers in the Broome County area, and we're looking to expand that to not only pediatricians, but OBGYNs too. And we've also developed 2 surveys too that we are looking to disseminate to these providers to kind of get a little bit more at some of the problems that they're facing, but also get more data too, so that we can address these problems and go back to the health department, give them this data, and then also talk to them too about ways that they can go about doing educational material and other outreach activities too. And one other part of the project too that we're looking at more recently is developing other educational materials ourselves to not only go to the health department, but also go to parents of school-age children too. So recognizing that, yes, a way to address lead poisoning and lead prevention is to go through providers and look at testing rates and looking at the barriers to testing, but also to how can we incorporate this into parents so that when they do go to these doctors' offices, or they can feel also the responsibility that they can also inquire about these issues. And kind of goes back to this last question too that a lot of panel members have been talking about, but what can the general public do and what can other people do to address these issues also? So this educational material that we're trying to develop is looking at current literature, but then addressing it to parents and other individuals with young children, and what can they do about these issues of lead poisoning. So not only bringing it up, they're living in rental housing, because New York State requires that every property should be tested for lead poisoning too, or lead exposure. So making sure that if people are renting houses, they do have that documentation that their landlords have been checking for lead exposure. And they can also clarify too that that their homes and their place that they're living in are free of lead and lead toxins, but also to having people be able to ask their providers too if they are able to go there too, or showing people that you can go to your local health department and there's other programs. I know specifically here in Broome County, there's other programs too that can look to address getting rid of lead poisoning and lead exposure in your homes too, and other ways. So it's also not only addressing too, like I mentioned, addressing from the provider side, but also giving a little bit of agency to parents and the other public to address these issues too from their perspective. I know it was very quick, but I also do want to leave time for questions if anyone does have that too. So I'm going to stop talking about my project.
All right. Well, thanks, Liam. Yeah, a lot of challenges embedded within that, particularly in terms of any remediation of lead paint by landlords. Big challenge. And also, I should just note for those from the area, Broome County is one of the highest percentages of lead paint exposure in the state. And also, clearly, these things line up back at disparities. Obviously, in those communities of color and those underserved communities have the highest rates because of the nature of the rental and those not being remediated, but also the incredible costs. Because generally, you're told, rather, if you're going to scrape all the paint, which is more problematic, you have to paint over that, but the cost involved with that is just, basically unreachable by law. And also, I think what we talked about in other contexts in the other speakers, just the whole notion of the parent's perspective, it is, you want to avoid sort of a shaming, right, to a degree as well. It's like, well, you're a bad parent because you weren't testing your child for lead paint. So it's a broader conversation to have with the community, definitely, as well. So yeah, we do have a little bit of time left. If people want to throw questions in for our panelists in the chat. And first of all, thank you to our panelists and others who provide some great resources and links about all the different things we've been talking about today. I think that's great and useful to have. Also, we will and are recording this as well. So, those who are listening in As panelists, please feel free to share with your colleagues if they're not able to attend this conference today. And just sort of, I think it's great information and really incredible insight on what's going on, even locally here in our community around health issues from a very broad spectrum perspective. So I don't know if I see any chats coming in, I'll mention those, but I know that our panelists may have questions for each other too. So I want to open that opportunity as well. I don't want to pass that by, but if there's something you want to, or something you wanted to add to your own conversation of hearing everyone else sort of talk about the work they're doing. I also think that participants can unmute themselves if you want to do it that way. You can also feel free to ask a question. We have down to about 5 minutes left, I guess.
I guess I'll just make one comment. I put it in the chat, but I'll follow up. I thought of it as Lindsay and then Jesse were speaking about the work that they do and the way that they allow the clients in their programs to identify their own priorities at their own speed is so important, and goes so far toward achieving health equity for people. And it's really, it's almost antithetical to the way that we've been doing things for a long time, is to give our clients that first voice to identify what their priorities are and when, because we all, as much as we don't like to think it or hear it, we all, we're in the health and human services fields because we are nurturers and we want to help people. But it gives us a little bit of a savior complex sometimes, and especially, we're all doing our work day after day after day, and so we start to think, well, we've seen this situation before over and over, and I know immediately what this person needs or what this family needs. But allowing people the space to make those decisions themselves is so important. And then the other thing that came to mind is that when we're thinking about trauma and the way that people are, even, right now, today, the way that people are making decisions about their health, think about what we've all of us, every single one of us have gone through for the past almost 2 years now. And the pandemic truly is a very long, stretched out traumatic event. And that's affecting the people that we serve and us as well, right along with them as we're watching people go through everything they've gone through. And so, I just wanted to make those 2 points just in terms of first, again, achieving health equity, but then also just recognizing that, everything that the frustration and the hopelessness and the fear and the concerns that we're seeing among the people that we serve, we all are experiencing some level of that as well.
Hi, I just wanted to thank everybody for sharing, and I really do appreciate the connection to trauma. I am a social worker by trade, and I didn't understand trauma when I was doing direct practice. And now the more I learn about it, the more so many things are connected to it. And the research that you referred to actually came out of a weight loss study that one of the doctors, like a woman lost a lot of weight, and when she went on to get a new job and she had this great opportunity, she had reached these goals, she gained all the weight back, and they couldn't figure out what happened. And what they found out is that work environment triggered trauma from her childhood, and that led to this. So much of this is really linked to our brain development, how we view our world, and then how we make decisions on our health. So such an important panel, and thank you all for all the important work you're doing, because it's really needed, much needed, before and now even more so after the pandemic. So
Thank you, Luann, for that comment. That's great. All right, if nobody has questions or any final comments, I want to thank our panelists and thank all of you that joined us today. I think we've got a great spectrum of the kind of work that's being done, and I really like an opportunity where we can have student researchers, faculty research, and in particular our community partners all joining in this conversation, because it's so much richer and deeper, I think. And always like to hear what's going on locally, but knowing that every issue we've talked about is not only a national but international concern as well. So I think all these topics you brought up, all the challenges we see globally, and I really like to think of that way in terms of the context of how we go ahead with our own work, whether we're in the health field or not. I think, again, doing a self-check with ourselves, with our families, and with our community, I think is important, just to be advocates for health across all dimensions. And I think on the entire spectrum, from birth to death, I think a lot of focus around childhood today was wonderful. And we know all those definitely things that go throughout the life course. And those are all things we need to be advocates for as well. So we're actually right at 11:30. So thank you, everybody. There'll be a very short break until we move on to the next part of the program for the conference. And that is our next speaker. All right. Well, thanks, everybody. Have a great weekend and be safe and be healthy as we move forward. Thank you.